Hello and welcome to another intensive care hotline and intensive care at home live stream. Thank you so much for coming on to the show. And I also want to welcome anyone who's watching this recording afterwards. I'm your host, Patrick Hutzel, founder of Intensive Care Hotline and Intensive Care at Home. And in today's show, we want to talk about the 10 benefits of doing your own research when you have a loved one who's critically ill in intensive care. And before I go into today's topic, you might, want to know what makes me qualified to talk about today's topic. I'm a critical care nurse by background. I have worked in critical care / intensive care for over 20 years in 3 different countries. And I have also worked as a nurse unit manager in intensive care for over 5 years. I have been consulting and advocating for families in intensive care all over the world for the last 10 years as part of intensivecarehotline.com. And I'm also the founder and managing director of Intensive Care at Home, an intensive care at home nursing service where we send intensive care nurses into the home predominantly for long-term ventilated adults and children with tracheostomies, but also for non-invasively ventilated adults and children on BiPAP, CPAP, VPAP, and also for clients that are not ventilated but have a tracheostomy. We also do home TPN. With Intensive Care at Home, we are currently operating all around Australia. We are an NDIS accredited service. We are also third-party accredited for intensive care at home services. We are also a preferred provider for the TAC in Victoria, with intensive care at home, the DVA, the Department of Veteran Affairs, as well as iCare in New South Wales, as well as any public or private hospital that wants to use our service. So that's a little bit about me. Just some housekeeping issues. If you have any questions regarding today's topic or any other questions related to today's topic, or about you having a loved one in intensive care, or if you want to know more about intensive care at home, just type your questions into the chat pad. I will also give you the opportunity to dial into the show if you want to. By the end of today's presentation, I will type in the numbers in the chat pad a bit later, how you can dial in live on the show, or you can also be a guest here if you want to put yourself on camera, or even if you want to join this live stream and you can, you don't have to get on camera, but if you want to join live on the screen, just send me a message that you want to join and I can get you in here, and you can also ask your questions here. Okay, without further ado, let's get into the 10 benefits of doing your own research when you have a loved one that's critically ill in ICU. And again, before I dive into those 10 benefits, this is really a direct result of me having talked to families all around the world that have loved ones in intensive care for the last 10 years, but also obviously having worked in intensive care for over 20 years in 3 different countries. So it's really a result of all of that. And it's a result of my interactions with, thousands of families in intensive care over the years. Let's dive right into it. So the first benefit that it does have is it leads you to a second opinion. And, when talking to families in intensive care, some of them identify correctly, well, we need a second opinion here. They've read our website, they can see that, what the intensive care team is telling them, they either disagree with, or they're not happy with it, or often they might even feel offended, and they strongly disagree with what's being presented to them, and that's when you need a second opinion. Now, the problem in the world of intensive care often is that if you get a second opinion from another ICU doctor, or they often mates covering mates, friends covering friends. They know each other. They don't want to hurt each other. So you really need someone independently that can advocate for you and give you that second opinion. Now, granted, I am not an intensive care specialist. I'm an intensive care nurse, critical care nurse by background. But, we have a team of intensive care nurses working here. We also have a legal nurse consultant on our team. And we can give you, the second opinion from a nursing perspective. But I still think it's a very valuable perspective. And if you look at one of the podcasts that we sent out on YouTube in the last couple of days, you will actually see that what we do, it has merit. So, for example, I published a podcast with one of our previous clients 3 days ago on YouTube. It's not on the blog yet, but it'll go on the blog in the next few days. And the title of the podcast is "Thank You Intensive Care Hotline for Saving My Life. You're a light of guidance to people." So when you look at the podcast, it's a video podcast, you will actually see that I've interviewed one of our previous clients where I believe we saved a life by offering that second opinion. Just listen to the podcast. It's all in there. There was a 58-year-old man in ICU, and the ICU team told the family that there's nothing they can do to save their loved one's life, and that they would take him off the ventilator the next day. And then obviously we successfully intervened by giving a second opinion and saying, well, why can't this man have a tracheostomy, and give him a good shot at treatment, which is then what the ICU did in the end. And there you go. 12 months later, he's on a podcast. Him and his family are on a podcast, saying that second opinion was crucial in saving their loved one's life. And he could vouch for himself that, he wouldn't be around if it hadn't been for that intervention / second opinion. Now, next, another benefit, second benefit, when you're doing your own research. It'll also lead you to either us talking to doctors and nurses directly with you, or it'll lead to a medical record review. Ideally, it'll lead to both, right? Again, why is this important? So when we talk to families in intensive care and they tell us what's happening, what they think is happening, we realize very quickly that what they're telling us is probably not even 50% of what is really happening. It's probably often 10 or 20% of what is actually really happening. They're picking up snippets of what the doctors are telling them, but still miss most ingredients of what's happening in intensive care. So when someone is in intensive care, critically ill, on a ventilator, for example, right, with one or more than one organ failing, right, there are dozens of things happening simultaneously. And unless you can get a good grip on everything that's happening, and I mean everything, you will fight an uphill battle, right? So I'll give you an example of what families are telling us, so you can hopefully relate to that. They're telling us, oh, my mom, my dad, my spouse, whatever, is on a ventilator. He's on 30%. That means nothing, and they say, oh, my mom, my dad, my spouse is on a ventilator. He's on 30% and he's stable. That's not even giving me 2% of what's happening. And it's not your fault. It's not your fault. I mean, working to even get to the point where you can work in intensive care, you need to either do, study medicine, or you need to get into nursing. But even then, it's a long road until you know and understand what's really happening in intensive care, right? So unless you can really understand the ins and outs of what's happening in intensive care, again, you have no idea what is really happening, So you need to understand about diagnosis, about prognosis. You need to understand about each body system: brain, heart, lungs, liver, kidneys. You need to know about things such as diabetes, you need to know about what medications are people on. You need to understand the ins and outs of ventilators. You need to understand the ins and outs of induced coma. You need to understand the ins and outs of hemodynamic support, such as inotropes, vasopressors, blood transfusions, how it correlates with blood results. You need to understand the interactions of certain drugs. You need to understand the side effects. You need to understand the long-term effects of certain medications. You need to understand procedures that can be done in ICU, such as bronchoscopies, central lines, arterial lines, and the list, ultrasounds, and the list goes on. Unless you know any of that and how you can piece the puzzle together, you don't really know what's happening, and you don't really know any of your options that are available to you besides the doom and gloom that you're already getting from the intensive care team. Most families that contact us telling us, well, we are told my loved one's dying and there's nothing they can do. And then when we look at medical records, when we talk to doctors and nurses directly, we see, well, there's lots that can be done. They just haven't told you, and they just don't want to do it for whatever reason. And most of the time, the reason is they need the ICU bed, or they don't think they'll be making any money. Next, out of all of this, out of number one, you're getting a second opinion, and out of number two, medical record reviews, or by us talking to doctors and nurses directly, you are actually feeling empowered. Now, you're probably already feeling empowered by watching this video, right? You can already see that there's help out there for you. So you're already feeling empowered just by someone giving you an alternative to, the narrative that they're trying to give you in intensive care. And the narrative is all but negative. Once again, I can't stress it enough. When you look at the research, approximately 90% of intensive care patients survive intensive care. That is fantastic news. That is fantastic news that 90% of intensive care patients survive. But the ICU team presents to you that there's no chance your loved one is going to survive. So unless, again, you are doing your own research and you believe the narrative they're presenting to you, you have already lost. With that empowerment, it leads me to number 4. You are finally in a position where you can have peace of mind, make informed decisions, and you have control, power, and influence, right? Now, the number of families that come to us in intensive care, that feel completely powerless or have no idea where to even start is enormous. But, just by you reading the blog, just by you watching the videos, just by you knowing that someone is there who can improve your life instantly when you have a loved one in intensive care, just by the mere fact that, we can move you away from the doom and gloom and from the negativity of intensive care teams, is a game changer, right? It's a game changer, and it presents a completely different reality, and you can choose to live in our reality or in the intensive care team's reality. I know which one that I would choose, and after 20 years having worked in intensive care, I decided for myself which reality I want to live in, right? And again, keep going back to the blog, to the video blog that I just posted a few days ago, or if you look at our testimonials on our website at intensivecarehotline.com, you will see, we saved countless lives. So again, doing your own research will get you to make informed decisions, have peace of mind, control, power, and influence. And you can live in your own reality, not in the intensive care team's reality. Stop buying into the narrative. Next, number 5. Another benefit of you doing your own research when you have a loved one in intensive care. You can actually make objective decisions, and you can get an objective point of view. I am not saying dismiss what intensive care teams are telling you. I'm not saying to you, but take it in, digest it, and then respond, right? You are not in control what you are not in control what other people do. You can't. Just Forget about it, don't worry about it. What you can control is how you respond. And that's the only thing that you can control. Make peace with that. Make peace with that. And act on it. And see how much in control you are. Don't worry about 99% of the things you can't control, because it's a waste of time. Just focus on the 1% that you can control, and you'll be way more powerful. And it will help you leading to making objective decisions. And by you making objective decisions, you can move away from the bias that the intensive care teams have. The bias is, well, your loved one won't have any quality of life. Your loved one won't have any quality of life. Your loved one won't survive. Chances are slim they're going to survive. And again, keep in mind, once again, look at the research that approximately 90% of intensive care patients survive. That is objectivity in and of itself, right? So, be objective at all times. Don't buy into the negativity and the doom and gloom. Make sure you know the facts, and the facts are that most patients in intensive care do survive. Now, again, disclaimer, I am not talking about quality of life. I'm not talking about what it might look like, what's the quality of life going to look like, and so forth. But the reality also is, if you buy into the having, quote unquote, no quality of life narrative from the intensive care team, well, once someone has died, there's definitely no quality of life. That's for sure. Right? That is for sure. So, what I keep saying over and over again, you need to make decisions today that you don't regret in 12 months' time. And the reason I'm saying that is, we have multiple inquiries every week where families come to us and say, oh, about 12 months ago, 18 months ago, I had a family member in intensive care. The intensive care team told us that it's, quote unquote, in the best interest for my family member to die, because they won't have any quality of life if they do survive. And then they find our website a year later, because they can't sleep at night, because literally they have second thoughts thinking, oh, have I made the wrong decision? And probably, yes, you have made the wrong decision, because your loved one could still be alive, or at least they could have had a second shot at life. And if intensive care teams keep trying and your loved one passes away anyway, okay, at least it was a real end of life situation and not a perceived end of life situation. And I'll come to the difference in a minute. But you can actually make objective decisions, starting from knowing that 90% of intensive care patients survive, and that then you can make an objective decision. Also, in this day and age, like I said in the beginning, with services like intensive care at home, there are other options available for your loved one to go home, potentially have end of life at home if your loved one isn't going to survive, have more time at home, in a family-friendly environment, not in a family unfriendly environment, which is often what's happening in intensive care. Now, moving along, number 6, sixth benefit of doing your own research when you have a loved one critically ill in intensive care. You actually know what's coming. You can see the pattern, because we can help you with that. I keep saying, that we teach you to speak a quote unquote secret language in intensive care. And that's pretty much all we're doing here. We are teaching you a secret language, because we've recognized the patterns. We know what's coming next. Again, look at our blog posts or testimonials that we're getting from clients, that we can almost walk them through step by step about what intensive care teams are going to do. So to illustrate some examples there as well is family meetings in intensive care. I can predict when they're being told, when they're being asked for, and then if you are having a family meeting and you decide to go there, I can predict what's happening there. But the good news here is I can also predict and guide you how to position yourself when you are being asked for a family meeting. And just for the records, once again, if you are being asked for a family meeting in intensive care, the first thing you need to do is ask for a written agenda. If you don't get that, you should not go there. Let me repeat that. If you are being asked for a family meeting in intensive care, you should ask for a written agenda, and only once you've received a written agenda, you should be having or should be going into a family meeting. But only then if you are happy with the agenda. If you're not happy with the agenda, tell them, I'm not prepared to talk about end of life. I'm not prepared to talk about PEG tubes. I'm not prepared to talk about whatever. You set the rules. Next. And also as part of that, because you know what's coming next, and this is unique to our families in the USA, in the United States. Often in ICU, you're being asked for a PEG tube in combination with a tracheostomy. And if you are, we are strongly recommending not to give consent to a PEG tube in combination with a tracheostomy, because once you've given consent to a PEG tube and your loved one has a tracheostomy, your loved one is at high risk of being sent to an LTAC, long-term acute care facility. Do not give consent to a PEG. I've made countless videos about that. Why? Go and check them out on our website, or Google them. Do not give consent to a PEG tube. No need for a PEG tube if your loved one has a tracheostomy as well. A nasogastric tube is perfectly fine. Next, number 7. Now I can't even read my own writing. So once you start doing your own research, you would have found out that there are more options for you available. For example, like I just mentioned, the example with a PEG tube. Don't give consent to a PEG tube. But other options such as intensive care at home. This is more for anyone that has a long-term, that has a family member in intensive care long-term with a tracheostomy in particular, not knowing whether they can come off the ventilator, not knowing how long it'll take for them to stay in intensive care. So your next step then is to look for options such as intensive care at home. Again, with intensive care at home, we're predominantly looking for long-term ventilated adults and children with tracheostomies. But we're also looking at home BiPAP, CPAP. We are looking at home TPN and any other medical complexities. So, all of a sudden, there's this whole world of options opening up for you that the ICUs don't want to give you, because they want to stay in control and they want to more or less make the call who's going to live and going to die, right? So please keep that in mind as well. So all of a sudden you have options. That is one of the biggest benefits, And again, especially if you are in Australia and in the US with intensive care at home, please contact us. We can help you to get your loved one home if that's what you would like, or if you are a patient yourself and you're watching this, it'll give you options. And also around end of life, for example, ICUs are often telling families, well, tomorrow at 3:00 we have to take off life support for your loved one, let them die, because it's quote unquote in their best interest. I've yet to find out why it's in the quote unquote best interest for someone to die, unless they want to, of course. That's a different story. But it's often being presented to families after 3 days in ICU. 3 days in ICU is not a long time. I was talking to someone this week. They have their loved one in the ICU for 9 days, and they're already talking about stopping treatment. And this is a 44-year-old man. It's ridiculous. That was something that I was heavily objecting to when I was still working in ICU, questioning the practices. So, and with end of life as well, think about, going home. If you want to have end of life care at home from intensive care, with intensive care at home, especially, if you're in Australia, in the US, please contact us and we can help you setting up home care for end of life care. Now, Jose is asking, the medical staff always ask if I'm in the medical field based on my questions. That's great, Jose. That's a compliment. That is a compliment. I'm sure you are a student of ours. I'm sure you're reading the website and you're watching the videos. That is our goal. And your name sounds familiar, Jose. I'm not sure whether I've spoken to you already, but your name sounds familiar. But one way or another, you should be proud of that. You know, you are learning the quote unquote secret language that we teach here, and that the ICU team doesn't want you to know, right? So that is great that you are doing that. Okay. Then the next benefit, number 8, of doing your own research when your loved one is critically ill in intensive care. You can have someone like us guiding you through the process step by step, because again, we recognize the patterns. And that's probably what you are referring to as well here, Jose, that, you know, you have recognized the patterns probably just by being a student, and you can now anticipate what's coming, you know, good or bad, but at least you can anticipate and you can work out strategies, what to do next, you know. And that is really critical, because ICU teams know what to do next. They know exactly what to do next. It's almost like, you know, that they've got a checklist of things to do. You know, after 10 days in ICU, if things are not progressing at the speed they want it to progress, you know, then they start to become negative again. And they might have been negative from day one. Very rarely will you find that ICU teams are positive. Why is that? Simply because they're trying to manage their worst case scenario. So let me explain that to you. What is their worst case scenario? Their worst case scenario is to look after a patient in intensive care indefinitely with an uncertain outcome. That is their worst case scenario, right? Because it costs a lot of money. They don't want to deal with stressed families, you know, they don't want to be dealing with all of your questions. And they have, unfortunately, they have other patients knocking at their door needing the ICU bed. And they also have often a staff shortage. So, but we know all of that, and we can walk you through the process step by step. Number 9, and this is a really important one. Actually, your most burning questions actually will be answered, you know, and they will be answered, you know, in a succinct way, because ICU teams can be very reluctant to answer questions, right? And like Jose said, you know, once they realize you have some knowledge, well, they're getting even more reluctant, because then they realize their leverage has gone. You know, once they realize you're actually asking the right questions, then they fear losing some leverage. So, but what do I actually mean by that your most burning questions will be answered? So I'll give you an example. When I first started out writing my blog 10 years ago, it was actually in 2013, in May 2013, so we're in business 10 years now. When I was starting to write my blog at Intensive Care Hotline in particular, you know, I got all these questions coming from families, you know, because there was nothing there. I believe we were the first blog that was really designed for families in intensive care. So anyway, all of a sudden I kept getting this one particular question that kept coming up over and over again, and I made a blog post about it. Now the question was, how long does it take to wake up after an induced coma? And that still to this day is our most watched video. Now, when you ask ICUs about that question, well, they will probably tell you, well, your family member will never wake up, so therefore it's quote unquote in the best interest for your loved one to die so they can have the bed, right? Whereas here you get a more nuanced approach, and it's an approach that is not tied to needing an ICU bed, right? The approach here is tied to what do you want? How can you best get the best outcome for your family member? That's the approach that we are taking. We want the best for you, whereas ICUs want the best for them, right? Other burning questions that families had when they came to us were, how long does it take to wake up after a brain injury, whether that's a traumatic brain injury or an anoxic or a hypoxic brain injury. Next, other questions we had is, how long can someone stay on a ventilator? How long before someone needs a tracheostomy? When should a tracheostomy be done? And again, it was not with the bias that ICUs have of what's in it for them. Our bias is what's in it for you. What do you need? Other questions that we had coming up, like I quickly alluded to earlier, when families come to us and they say, oh, well, ICU told me that tomorrow at 3:00, they want to take my mum, my dad, my spouse off the ventilator and let them die. And is it, because they're telling us it's in my mum's or my dad's best interest. And we call nonsense on that, right? I mean, that could be perceived as euthanasia, could be perceived as murder. Both is illegal. And we have we have helped families to go to court with situations like that. And, we've never had a situation where we couldn't help families in the situation like that. As long as families can follow advice, we can turn these situations around. Which leads me to, the difference between a quote unquote real and quote unquote perceived end of life situation. Big difference, big difference. So what's a real end of life situation in ICU? A real end of life situation is, your loved one is in ICU. ICU is throwing all resources at your loved one. They're moving heaven and earth, offering all treatment. And if they couldn't offer all treatment, they would offer you to send your loved one to another ICU. And if your loved one then still can't be saved for whatever reason, that's a real end of life situation. A perceived end of life situation is if, again, I keep coming back to the video that we put out this week, where we were working with a client last year where ICU told them, that there's no chance for survival. Tomorrow they will stop life support because it's quote unquote in the best interest of the patient to die. Where we objected, offered a second opinion, and that and we spoke to the ICU, and then all of a sudden the patient ended up with a tracheostomy, and 6 months later, 12 months later, the patient is still alive, sitting on a podcast sharing their story. That would have been a perceived end of life situation. And a perceived end of life situation very rarely leads to someone dying, assuming you're doing all the right things, assuming you're being ethical, and assuming you are offering all treatments available, right? So, and then last but not least, number 10, the tips and the tricks, and you're becoming an expert in ICU or pediatric ICU, because again, we can guide you step by step. It sounds like, Jose, you are an expert now. Well, an expert in a field that you probably didn't want to become an expert in to begin with, but nevertheless, now you've probably worked out all the pitfalls, and you know how to position yourself, and you know how to position your loved one. Now you are probably at the point where you are managing doctors and nurses in intensive care so that they can't manage you. And that is always our goal. When families come to us, we realize very quickly, well, ICU teams are managing you, and you need to start managing them, right? Very big difference, big difference. You need to start managing them and not the other way around. And to get to that point is taking some learning and some efforts, right? Steep learning curve. But you need to start the process. That is really important. So that sums up the 10 benefits of doing your own research when your loved one is critically ill in ICU. If you can think of any others, please comment below or comment now, or, I have other questions that I want to go through, questions that are coming in every week. So I'll just read out questions from readers that we have. So one question that came in was from Loretta. My brother nodded yes when asked if he wanted some ice cream today. Again, if he's in a medically induced coma for being septic, they have been lowering medications to try and bring him out of his coma slowly, and also having a tracheostomy to be scheduled. Do you think that is necessary to do a tracheostomy? Can you give me your personal opinion on what you think about the situation right now that I just told you about? From Loretta. Look, Loretta, it's difficult to say whether your brother-in-law needs a tracheostomy or not. And this is what I'm saying over and over again, that the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. This is a typical example that you don't know what you don't know. So, and what I said earlier on the show, where families are giving us 5-10% max in order to answer their questions. So, does your brother need a tracheostomy or not? I don't know, because A, you haven't shared with me how many days he's been in ICU with sepsis. You haven't shared with me what are his ventilator settings. You haven't shared with me what medications is he on, what are his blood results, what sepsis did he have, what organs are failing, what sedation is he on, what opiates is he on. Only if I get all that information, only then can I tell you whether he should have a tracheostomy or not, right? And this was one of my first points in today's presentation, where I said we either need to talk to doctors and nurses directly, or we need to review the medical records. Ideally, we do both, right? Chances are ICU wants a tracheostomy because they want to send your loved one out if you're in the US, for example, right? In another country like here in Australia, if your loved one needs a tracheostomy, what's the plan forward from there? Can he go home with intensive care at home? What are the options? So therefore, whilst you have a great question here, Loretta, I don't have the answer with more information, right? That's why I keep saying intensive care is such a highly specialized environment. Unless you've worked there for decades like I have, you don't really, then I can fill in the gaps with what questions need to be asked. Then I can give you a succinct answer to your question. So next question that came in from Juanita, who commented on a video, who said, "Oh, thanks for the video on YouTube. I was waiting to hear about how being on the ventilator is or isn't a risk to the patient being able to speak, the vocal cords, the voice." Great question. So first of all, Juanita here, most importantly, a ventilator, putting someone on a ventilator should be a last resort, okay? The vocal cords are paralyzed when someone has a breathing tube in the mouth or a tracheostomy, okay? So could there be some long-term vocal cord paralysis? Sometimes. That is definitely a risk that needs to be assessed, especially for tracheostomy patients. If someone has a ventilator in situ for, in the breathing tube, maybe for 24, 48 hours, when you extubate a patient, it's pretty much that people start talking again straight away after they've been extubated. Okay, so it's really no big deal in terms of the vocal cords. People have a hoarse voice to begin with, and then you give them some ice chips and, things normalize pretty quickly. But it's definitely a concern. And sometimes when patients have been ventilated long-term, like for weeks or for months, and then they have the tracheostomy removed, yes, there could be some vocal cord paralysis. It's also with children, for example, children that are long-term ventilated, maybe from birth, because they've been a prem baby or whatever the case may be, there's often a delay in them starting to talk as well. So I hope that answers your question there, Juanita. Let's move along to the next question from Emma, who says, what are some preventative measures we can take to prevent my dad from having another pneumonia or respiratory complications, given that he recently got his tracheostomy tube removed and seems to be doing well with the swallowing of mashed foods and thickened drinks at the hospital? Considering in-home medical care for my dad because of the inadequate level of care being given by a skilled nursing facility, would care providers at home be able to provide proper health care for my dad? He's a TBI survivor, 70 years of age, not mobile with speech and vertigo issues. Please explain if your in-home care services are available in Los Angeles and area. If so, would like to know if you're able to bill Medicare. So I remember we've worked with Emma earlier in the year. Look, one way, or one of the biggest sort of measures to prevent a pneumonia, especially for someone who had a tracheostomy, is deep breathing exercises, coughing exercises, and of course mobilization, physical therapy and so forth, right? That would be one of the ways to prevent a pneumonia. And given that he's now doing well with swallowing mashed foods and thickened drinks, that's really fantastic that he's doing that. You just need to make sure he's not aspirating, or not even at risk of aspiration, because that also comes back to the previous question. If someone has vocal cord paralysis, they may also have difficulties swallowing, but it sounds to me like that's not the case here. So if he's not mobile and he's got vertigo issues, of course mobilization needs to go slowly. Is our home care service something for your dad? I'm not sure, because we are really specialized on predominantly long-term intensive care patients, and it sounds to me like that has passed sort of that stage. It sounds like he needs more general nursing care rather than intensive care at home. That's what it sounds like to me. Are we in Los Angeles? No, not yet. But what you can do is you can contact us anyway, because we can put you up with providers in LA. We have contacts there. Next question from Farhan. Farhan says, my wife is in ICU because of brain hypoxia, and she has been in the last 6 months. She has a PEG and a tracheostomy tube, and she's very weak. How can we assess whether the trach tube can be removed? And if it can't be removed, can she go home? Okay, great question, Farhan. Absolutely, she can go home if she needs long-term ventilation with the tracheostomy with intensive care at home, right? No question there. So if your wife needs ventilator and the tracheostomy, it's difficult for the tracheostomy to be removed if she has the ventilator as well. If she does need tracheostomy and ventilation in the long term, she probably will need a PEG tube in the long run. So in this situation, it's the right thing to do a PEG tube. In regards to the weakness, your wife should get out of bed, should get mobilized, should get in a recliner chair, should have physiotherapy/physical therapy. But again, also like with many other families, your biggest challenge is that you don't know what you don't know, i.e., given that she's ventilator dependent, she can't have the tracheostomy removed most likely. If she has a hypoxic brain injury, it also means she most likely can't swallow, which means she probably will need the tracheostomy, right, and the ventilator and the PEG. So yes, but she could go home with intensive care at home. It sounds, that's bread and butter for us, to take someone home like your wife with a condition like that. I hope that helps. And you can contact us at intensivecareathome.com. Call us on one of the numbers on the top of our website. So I want to wrap this up for today. If you have any questions, still type them in the chat pad now. Type them into the chat pad now, and then I will get to them. If not, I will be back next Sunday, 10:30 a.m. With a live stream, Sydney, Melbourne time. That is 8:30 p.m. Eastern Standard Time in the US on a Saturday night, which is 5:30 p.m. Pacific time in the US on a Saturday. That's when I will be back with another topic. I haven't worked out the topic yet, but there's so many topics on my list. That there's probably something for you on the stream. So if you have a loved one in intensive care, go to intensivecarehotline.com and call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. I do offer one-to-one consulting and advocacy for families in intensive care. We also offer medical record reviews, of course. If you are in need of intensive care at home, please go to intensivecareathome.com. Again, call us on one of the numbers on the top of our website, or simply email us at info@intensivecareathome.com. With Intensive Care at Home, we're also providing NDIS support coordination, NDIS specialist support coordination if you are in Australia, and we can help you with the advocacy process to get the funding for intensive care at home. Now, please also have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care and intensive care at home related. Also, if you need a medical record review, please contact us as well. We do medical record reviews in real time for your loved one in intensive care. We also provide NDIS nursing assessments if you need that as well, again, for our NDIS participants who have ventilation, tracheostomy, seizure management, non-invasive ventilation such as CPAP, BiPAP, or home TPN or IV infusions. Please contact us for an NDIS nursing assessment. We also review medical records after intensive care, of course. If you have unanswered questions, if you're suspecting medical negligence, or if you are simply needing closure. Now, thank you so much for watching. Like the video, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Share the video with your friends and families. Click the like button, click the notification bell, and comment below what questions you have or what other topic you want me to go about. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. Give the video a like, and I'll talk to you next week. Take care.